Yeah. Okay, so good morning, Dr. Chitra, and thank you so much for joining the Sabar team today for this conversation. It's a great pleasure to have you here. Having known your work for so long, but also so it was almost obvious that we had to have a conversation with you if we were going to talk about anything regarding care for the people. So if you could just start with telling us a little bit about what is it that you do currently in your work with Mehac, and then maybe we could take the conversation from there.
Thanks, Devi. I mean, I think it's a privilege to be talking to you with such collectives like Sabir. I mean, the name itself is so, inspiring for me. And I think it's also very meaningful to have such collectives, whether it's related to healthcare or any domain or, dimension for the society these days, to make sense and to bring in meaning and purpose to a lot of young minds, I suppose. Because there's a lot of things happening which kind of leave people either confused or very focused on something which is very narrow, and kind of it's like wearing glasses which just focus on a particular kind of um, spot in your life. So I think it's very meaningful, and thanks for that. Okay, let me start by saying my experience, or where I come from. So I'm basically a mental health professional. I qualified, trained as a psychiatrist in Kerala. Um, so again, the question comes that why did I choose psychiatry? Many people ask me, many of my own, friends and people who studied with me used to ask me, why did you choose psychiatry? I was a fairly good student also. So people in medicine, when you train, you are expected to be taking one of those glamorous specialties, like medicine, surgery. Um, I mean, the priority changes every year, but psychiatry doesn't come too close. I mean, these days psychiatry is quite sought after because it's a one-end specialty. Many one-end specialties are now looked for rather than doing DM.
Yeah.
So because you don't have space for too many super specialists. So one-end specialties, and then also psychiatry is very lucrative in private sector. So, but I chose psychiatry because for me, I think that was a time when I started really thinking about mm, what am I really going to do, in the sense that what is my role in that sense, like you become a doctor. I mean, I did have very conventional ways of thinking that, I will do this, get into a hospital. I mean, of course, the intentions of everyone is very good. They want to take care of people. Then how do you do it is the way that you take, the path you take. So then I kind of left a very good specialty in All India Institute of Medical Science, New Delhi, and I chose to do psychiatry. Psychiatry is a specialty we don't really learn much in your undergraduate training, though we do get questions, and these days it has changed a bit. But when I was studying, it was not so, you don't so much seek for um, such information. Also, people don't really facilitate that process. I mean, of course, a few would have thought about it and would have sort of, I mean, they do seek because they're interested in psychology and mental health issues. So, but I chose because I was in such an environment also then, that I wanted something which was very socially relevant. I think, I mean, there is public health for all specialties, but then I wanted to do something where I thought that the society is really, there is some sort of neglect, or there's some sort of gap. So I thought I'll do psychiatry, and I also wanted to uh, do a specialty where there was so much of focus on the relationship and communication, and it totally depends on how you care for that person, because it's very subjective in the sense it doesn't have very objective elements.
Sure.
The specialty. So that's how I got into psychiatry, but the training as such really takes a biomedical model, I mean, a medical model again, even in psychiatry, though there's a lot of psychosocial focus and emphasis in terms of what you read and what you learn. But when you treat people, when you manage people, somehow there is a focus on a medical model where again, it's very prescriptive, and
Sure.
things are changing, but still. And then I was doing my MD in psychiatry in Calicut, Kozhikode in Kerala. It was actually unfortunate for me. I was wanting to do it in Trivandrum, where I did my undergraduate course, and I had family there then, and I had to live in a hostel in Calicut. But I think that's where I also believe that fate has some, destiny. You're destined for certain things, because palliative care was also growing in Calicut at that point, Kozhikode.
Yes.
So initially, it was just going for some consultations from the Department of Psychiatry, and then following which. My roommate was a person who was working in palliative care, and then I really wanted to go and do a 10 days volunteer kind of period with palliative care, because I was so impressed with what they were doing in terms of the comprehensive total care concept, having a multidisciplinary team, doing home visits. So it was very inspiring for me. And then I went and met Dr. Suresh Kumar in PPCS, which was known as the Pain and Palliative Care Society, then in Medical College, Kozhikode. And I did a short volunteer period, but then kind of extended to years. It just automatically, because I think the inspiration that that program gave me was tremendous. I think that was the significant milestone where my life changed, took another turn. So then I realized that this is the way I want to do work, whatever specialty. And this is the way people should also, incorporate these principles in wherever they are, and they should deliver care. So that is how I see palliative care. I don't see palliative care only as a specialty or a program.
Sure.
I see that as a philosophy. I see the principles behind it. I see that the values and what palliative care can bring in for healthcare movements, not only in terms of care delivery, but also in terms of growth of a person as a professional, as well as an individual, as the values that it brings to education and the society is of immense quality and nature. I think I say this because it happened to me. I'm not saying it's just for the sake of saying, but I changed as a person. I changed as a professional because of that experience. Even now, I'm very much involved in palliative care. So that was a turning where I started spending time in palliative care teams, being a palliative care physician, but also using my training in mental health to kind of leave an influence, or bring in changes in the way that mental health issues in palliative care can be taken care of, the training in issues in palliative care like communication skills and the mental health issues can be taken care of. So my role also changed. Initially, I was doing all that a palliative care physician would do. Then I also started looking into the mental health issues and also training people, beginning of, taking forming a core group within the palliative care team, which would focus more on psychosocial issues. So that changed the same, because when I came into palliative care, when you go for conferences, you would see very basic issues like communication skills, or just talk about depression, anxiety, or something which is very broad. But then I could see the difference which went into further larger dimensions, and how we could really integrate the psychosocial issues with the larger palliative care framework. So that is how my road to mental health in palliative care started. And then we used to do home visits. Like one doctor used to do like 4 months a year. So we were out on the field so much. And when I used to do palliative care visits, I used to see families where there was one person with a mental health issue, purely, like schizophrenia or bipolar mood disorder, very chronic, but quite neglected or not continuing the medications. The nature of the illness is such that people often do not continue the treatment because of several reasons, because they think that there is nothing is happening. Persons are getting the illness again. They cannot afford the medications. They cannot access proper psychiatric care. So I used to informally, manage these people with medications, and then when I used to do review, there was a lot of change. For these people at home, they're not going to see a psychiatrist, but at home, they are able to have a better quality of life. So that's when I started to advocate that mental illness, especially chronic mental illness, should be included in this, this broad, palliative care, illnesses, or, you have a certain range of illnesses, variety of illnesses that you have. So I started saying that mental illness should be included in this because their quality of life is also appalling. So they need an approach which will address their issues and improve their quality of life. Of course, I mean, they might not be one of those really life-threatening or, people who are looking at end-of-life care immediately. But definitely there is a great deal of morbidity and there is an excess of mortality in such people. Sure. So that's how Mehac came into being. So started that very informally, and then I had a opportunity to go to the UK to do a research program for around a year and a half or two. And when I was returning, I had the space to think about it. So I was working in Amrita Institute of Medical Science at that point in psychiatry, working with palliative care departments, but also doing psychiatry at that point. So I thought that I should start working in the community again fully. And I thought that even if it's just a small number of people, we should be able to do something different for these people. And that's how Mehac came into being, where we started saying that we are trying to improve the quality of lives of people with mental illness and their families. The same kind of definition that palliative care has, but focusing on mental illness and also the mental health issues of people with other chronic illnesses. So this was around 14 years back. And we started first with Calicut, in Calicut only, with the clinics there, the palliative care clinics there. And then I shifted to the southern part of Kerala. Yeah. And then we have been now working for 14 years here from 2010. And we have around 25 clinics in the community. We do home visits. We have a multidisciplinary team. And we are able to kind of address issues in a very proactive manner. So we go out in the community, and so we have established partnerships with organizations in the community. The organizations could be other not-for-profit organizations. They could be just institutions where, there are a lot of homes or institutions where people with mental illness are abandoned or left by the family, so that they can because they are sometimes not able to be managed at home. And sometimes family also kind of abandon them. Yes. So they'd see no kind of respite to this continuous care that they provide. Or it could be ill parents or, very old parents who have no other support. So we partner with them also. We partner with panchayats. We have started partnering with panchayat, and that seems to be a very sustainable way of giving long-term care. So in a panchayat, there is a primary health center. And then you have, in Kerala, every primary health center also has a palliative care team with an auxiliary nurse doing home visits and ASHA volunteers very actively identifying people. So we train the ASHA volunteers and the palliative care nurse and the stakeholders in the panchayat. And we have a program where one day is allotted for mental health. So for home visits also. So the ASHA volunteers identify people, palliative care nurse, along with Mehac social worker goes for home visits. And then we have clinical service, outpatient centers also. So we are trying to do that so that we believe that this is one of the feasible ways in which mental health care could be integrated at the primary care level. It's very feasible. It's cost effective. The medications are provided in the primary health care center. So a person with any other chronic illness goes to the primary health center, like diabetes, even cancer now, and takes medications. And in our panchayats, a person with schizophrenia or bipolar mood disorder goes to the primary health center and gets the medications. So I think the integration starts from there. So that's in short that we do. I mean, I can say more if.
Thank you. No, that was fantastic. And there's so many questions I would have in response to what you've just said. But maybe I could just start with something that you mentioned, and maybe for an unfamiliar audience, you talked about the philosophy of care that is there in palliative care that was deeply influential for you. And maybe if you could elaborate on that a little bit.
Yeah. So, for very theoretically, you can say that we, when we are trained in medicine, usually the medical model is one which is, comes, right on the face, like when there is an illness, the cause and the effect, and then you treat the cause and the effect also is managed. So like an infection, like, you give antibiotics and the infection is sorted out. So that's a very simple way of putting it. I mean, it's not so, and I'm not saying that everybody only takes care in the medical, I mean,
Yeah.
they do. I mean, I'm not generalizing this, but that's a model that you're taught. And then often you get carried away when you're in the hospitals by looking at that, the investigative part of it. So the person in that care, the person-centered care that we say, sometimes is not really visible. And people, I mean, the intentions are all good, that people want to kind of cure and solve the problems of people and the families. But then uh, the, the real person-centered care, like seeing that person as someone, as a person, and not as a patient with illness, with illness's name, as a case, um, uh, still is prevalent. And then you do according to certain guidelines that are there without giving consideration to the person or the family, like end of life care. What is the person's choice? What is the person's need? What are their decisions? What is the family's decisions? Are we following a very paternalistic kind of model where we say and people follow our instructions, or are we following a model where there's a mutual agenda? You take their priorities also, and then you kind of try to blend the agenda and give consideration. See, it is the person's priority which should be given consideration. It's not yours. Of course, there are some times when we have to say, no, let us take care of this part of the illness, and then we'll do this. But then we do need to have conversations like that with the people, to find out what is really bothering them. In a daily clinic, rather than being very prescriptive and just write medications and spend little time. How do you use this time effectively to find out what is in the person's mind? What is troubling them? Because often coming to a hospital is quite intimidating, for people, and they also, and in our culture, they are also very grateful. They think that doctor is very busy, they're giving us this time, and we should only, ask questions which are very pertinent, or which are acceptable also. How many people will say that I do have pain, I do have these issues, but what is really bothering is that I'm very anxious and I'm not able to sleep. So those kind of, changes, I saw that in palliative care, where, people really, that really comprehensive care concept is followed, where you sit with people, talk to them, find out, you spend time with them, you listen to them. There is active listening, you listen to them, you understand. And then that relationship is given so much of importance. So it's on the basis of that trust and that relationship and that rapport that you build that care you want to give for that person. So that those kind of very simple things, and then using a multidisciplinary team effectively. Like you work in teams where there's absolutely no hierarchy in that sense. Of course, doctor decides what has to be given, but we don't kind of order, or when you go onto the field, you actually work as a team, and each one has such a strong and individual unique role that the kind of hierarchy that you see in general medical settings, I saw that change in palliative care. So all these things, like that holistic care, the democracy in that team. So it's not only about the individual role, but it's the democratic, kind of environment that palliative care provides for people, the volunteers who come from the community to take part. In home visits, we have volunteers with us. So they have a very strong role, and we are behind them there, not in front of them. So all those things are very important to understand. So I think that's the value that, and also like values like compassion, empathy. How do you maintain the honesty and integrity in that relationship? How do you empathize with a person? What kind of communication skills do you need to have that? How do you have that compassion for the whole society? All those things, those values are important for people in medical education. That you also instill those values along with the knowledge that you instill in these young minds.
This, this sounds amazing, right? But I mean, even the Lancet Commission in 2022 was talking about values of death and talked about the Kerala model as utopic, right? If there's one example of a utopic model that exists here, it is. And so even when you are talking about it, and I've witnessed this as well, so I believe you when you're saying this, but also looking at different parts of the country, as well as different care providing models, like say, for example, a corporate hospital model. We often don't see this, right? It's so much of expert driven care on one hand, but also just that palliative care doesn't seem to have the same model when it goes outside Kerala's borders. So, I know this is like I'm asking multiple questions, but
No, no, I should also say that things are changing. Like, I wouldn't generalize that every palliative care, this kind of palliative care exists only in Kerala. So that is changing, because if you see Hyderabad, Dr. Gayatri's unit is doing tremendous work, and she's carried all these values and the comprehensive care system. It's a very good model what Dr. Gayatri is doing with all kind of settings that's there. There's the outpatient, the inpatient, hospice, home visits. So there are many centers in India which are coming at, and even in institutions like you have palliative care in regional cancer centers or autonomous institutions like the All India Institute of Medical Science. Most of the AIIMS have palliative care, and because there is a lot of teaching and awareness is coming up across India, it might be not the same model which is being transferred, which I don't know which will be effective, but the values are definitely transferred to different levels. I'm not saying that it's the replication, and I don't know if we need a replication, but of course people are trying to do this. So I will not generalize and say that this is limited to Kerala borders. In Tamil Nadu, there's a lot of programs. So Dr. Republica's program in Chennai, Dr. Mallika Thiruvadan and Trichy has a wonderful program. There are many programs. Vellore has a very good program. So there are many people who are striving for excellence in palliative care and also trying to conserve these values. Some might be in the infancy, in the stage of infancy, but people are focusing and trying to improve it. So I think palliative care definitely is in a stage where things are looking up, and there's a spread of palliative care across India, but definitely not to the extent that we would envisage or what would want. And still, only a small percentage of people have access to palliative care or to pain medications or to a comprehensive total care model. So things are changing, definitely. Yeah.
That's heartening to know, and I'd love to follow up on some of those.
I can actually help you find the contacts and to meet people and to witness what's happening, because each setting comes with its own limitations and its own medical models. The health systems that exist in an area is also very different.
Yes.
So then how do you plan your agenda integrating with that system? That's also very important, because it is quite palliative care in Kerala came at a time where there were conducive factors and champions, and we were fortunate to have all those things happen like 20-30 years back. But if you wanted the same model to start now, we will find it difficult.
For sure.
Because of resources and all those things. So see, volunteerism is a big thing in Kerala.
Correct.
So we started long back, so that movement has been progressing. But in a very with economic recession and consumerism and all those other factors also, it is very challenging for us to initiate new projects and to have these partnerships in the community like before. Things are happening, but then there is a relatively more struggle. I think so, and maybe the palliative care leaders would have struggled at that time too. But I'm saying this from what I saw. So I find it much more challenging these days in terms of the politics, the socio-political environment that we are in also.
Yes.
So I think each palliative care program is now developing, adjusting to it in the milieu that it is has to flourish. So it would be very interesting if you would make a few visits.
For sure. No, I'd love to also follow up on some of these other experiments that are happening across the country.
For example, I told about Dr. Gayatri's. For Dr. Republica's model is, so she has really, I mean, there would be questions, but she has really combined a business model along with the very charitable and compassionate model, and she runs both very well.
That's fantastic.
So, and that's actually something which we may have to think sometimes for sustaining certain programs, because where does the money come from?
Yeah.
Of course, in Kerala, much of the money comes from the community,
Yes.
from the volunteers and from the organizations which are set up by people in the community. But it might not work in other urban areas. So then what do you do? So people try to develop unique models for their own settings.
Yeah. But if I could go back to the point that you were making, that, doctors in both the palliative care work, but also the work that you're now doing through Mehac, where you work in a non-hierarchical, or at least you try to break down the hierarchies, and it's democratic, and that each person has a role. Can you tell us a little more about how do you make that happen? Because, I mean, my understanding is that doctors have a certain status and hierarchy.
Definitely they have. And it has to be very conscious and deliberate kind of way that the leadership should take in that. Because, I mean, often it should have a balance also. Because often when you become very democratic, and it's not saying that you're letting loose and everybody can take their decisions at all times. So that will be quite a mayhem. So how do you maintain a balance where there is a system of, how you plan projects with the leadership, and how you, within that, how do you encourage people to grow and to nurture them, to make them leaders, on their own, and to be confident in the community and take decisions. Sometimes when the other seniors are not available, you might have to take decisions based on our values and the mission that we have. So it is quite challenging, and sometimes people do not really come up to do that, because they look up to the doctor and the seniors as someone who has to take the decision. And to make them, to enable them, I think enabling is a very, very important process that we have to consciously do. So what I can say about myself, of course, I have a very strong and important role in terms of supervision and taking decisions in terms of the organization as such. But then I do a lot of delegation to my staff, whether it be the doctors working, or the psychologists, the social workers. I allow them to take decisions, and I also allow them allow mistakes to happen. I think, I mean, of course, we have discussions, and sometimes I do lose my cool, but there is also the sense of, that you are free to do that. So that has to be very, obviously kind of expressed to your team. And then also to have them plan and get ideas for them to create projects. So it's not my own thoughts that come into it. So I make it very clear that it should not be my own thoughts, because I come with certain set of thoughts depending on my experience, but people would have their own new innovative ideas, which I should welcome.
Yes.
If it aligns to what we want to do. So I'm not strict at saying that this should be only like this. So I allow them to say that, can we do this way? Can we try this out? And I think the pandemic and the floods in Kerala helped us also, because when you have a crisis which comes from outside, then you have no control, isn't it? I mean, like the pandemic, for us, the home visits and our role in the community was so strong that we were kind of left for a while. What to do? How do we manage these patients, and how do we still maintain that presence in the community, as well as how do we take care of our teams, because it was all doing over the over tele platforms and all those things. So we But the surprising, or and also reassuring aspect was that we worked really well during COVID and the floods, because I think one is because we had a network already established in the community, so the network came up very proactively to support us also. So
Sure.
like it's like, for example, if it is Alleppey, where we have a lot of clinics, they worked with each other very well,
It's amazing. Yeah.
and how they supported each other. Like if one family didn't have medications, we were able to get medications from that local, rather than Mehac going there. They really worked well, and we were able to also help other organizations, because we had already had networks in many districts. So that was one. That was already one, and then because of, like, I'm just bringing in how what you establish or what you instill can help you during crisis. So, and also the relationships that when I meant about values, because of the relationships we have with the stakeholders as well as the people, and with the people with mental illness and their families, they were also saying that, no, you shouldn't travel now. Please don't take risks, because we are not like a typical palliative care unit where you have to go for end of life care. We were able to, because we were focusing on mental health issues, we had that advantage of doing this from a distance also. So even we had patients, people with mental illness telling us that please don't come, we will call you over the phone. So people started using WhatsApp and all those things. So I think all those things helped us to think that, okay, we don't have to do exactly the same way before COVID. We can actually allow ourselves, some space to think over and replan or reimagine how we can do. So there are options for doing this in different ways also. So often what happens is, when we start a program like this, we stick on to this, and we find it we are desperate to continue the same way of things. And when it doesn't happen, we become very desperate and actually very disappointed. So these experiences during the pandemic, the humanitarian crisis, Kerala has been having it quite often.
Correct. Yes.
It helps us think that we are humans, and we can also step back and think and see how we can deliver it. So we have changed the way we approach. We make it much more, acceptable to everyone, rather than, imposing something.
Sure.
System. So I think that's the way I think. So in that, I think the team took a very strong, active role. Yeah. More than me. So I think that, and because we also focused on their own stress and, the burnout that they would feel. So I think that also enables them, and also there is an encouragement that happens within the team. There is a bonding, harmony. All that is very important when you work as a small team and you want to focus on other people, and when there's a lot of morbidity and mortality. So I think that is very important. I don't know if I answered your question, but
absolutely, I think so much, and beyond as well, in the question. But I get the part where you're working with different teams and different communities as well. What about working with the state? Like, because you work so closely with the panchayats as well and primary health centers, how has that experience been for you?
Working with the panchayats has been always, we have only progressed. That I can say, the numbers are increasing. Because you see, when you work with one panchayat and the medical officer there finds the benefit that such care is happening, when they get transferred, they call us and say, can we start that here also? So, so they are also, it happens. It has been progressing, and we have also improved in the way, initially it was very informal. We used to go do it. Now we have an MOU with the panchayats. We meet the panchayat people regularly. So in that way, that has really improved. And with the Muhamma Panchayat in Alappuzha, it has been we started that was the first panchayat other than Chota Nikara in Ernakulam. And in Muhamma, palliative care started in southern Kerala in Muhamma. And we had very, very, legendary leaders there from the community, from the political arena also. So they used to see that mental health was an important part, and they sought out for, a mental health clinic also. And we have been able to really improve there. And we also started another program in Mohama, which is probably the first panchayat-led Home Again program. So Home Again is a program which is pioneered by now the organization The Banyan, based in Chennai, a pioneering non-profit organization. So they started this program called Home Again because they focus a lot on homeless mentally ill. So these homeless people, they are reintegrated into the community. So rather than institutionalizing them, we are trying to find out homes within the community with people from the community trained as their personal assistants or caretakers, and then 5 or 6 people in the same gender live like a family. And then they live like a family. They have a medical supervision from a social worker and a psychiatrist, but and the personal assistants are also trained to identify symptoms and monitor them and give medications. But these people live like any other family. They go out. They go out to pray at the temple, church. They go out for to work. They get enrolled by the panchayat for the Todil Arappa, that is the rural employment scheme. The panchayat, so many such things happen. They are invited by families nearby for weddings. So we try to facilitate that process where they have that. So Mohama was the first panchayat to take it, to partner with us to have one home. So they gave us a building for that and all those things. So in that way, panchayat's program has been increasing. But and we also have worked with the National Health Mission, NRHM, when it was NRHM, in Ernakulam district, because we had connection with Dr. Matthews Nambeli, who's also one of the lead in palliative care in Kerala, was the district program manager of Ernakulam, and then we were able to do a lot for mental health when he was there, especially during the floods. We were able to pitch in, and we started clinics in a lot of panchayats at that point, because post-flood there was a lot of mental health programs. But that's the good side of it. I mean, of course, we face a lot of challenges. I mean, to be very honest, we have not been able to make great inroads into the state programs, or what should I say, partnerships with the state, in the sense that we have a very efficient district mental health program, and we look forward to partner with those programs, because I think we can still partner with them and function as, because we can function at the ground level and the primary care level and fill in the gap of follow up and all those things. But we have not been able to really establish those partnerships, because we have not received such a response also, to be honest. And there's a lot of questions or concerns or doubts regarding not-profit organizations. What is the agenda still in Kerala, which is very surprising for Kerala. I see that happening a lot in Tamil Nadu.
In Kerala as well, we've seen
that. Yeah. In Kerala, they do. In palliative care, they do a lot. But in some, I have not seen that in the mental health arena for us. I mean, I cannot generalize it, but so that is still a challenge for us. That is still a challenge for us, where we are working towards partnerships with the state. I mean, we do not want to replace them, or we do not want to. So there are a lot of questions about how we work and what's. So we are just saying that we are here to support the program and work with them to improve the programs. So that has been a challenge for us. And there's a lot of, I mean, we did have once the state also releases some budgets for every year for programs like this in the community, and we were actually selected just around COVID. We had a good budget granted to us, but we never got the money. Because again, when it comes to the implementation of that budget, it becomes very hierarchical and bureaucratic. So it becomes very difficult. So that kind of bureaucracy is still prevalent in Kerala.
And you mentioned that some of these initiatives at the panchayat level have been towards not institutionalizing patients or persons in this.
Yeah.
So with your experience in Mehac, through this experience that you've had, now that you look at the way psychiatry functions in hospitals, I mean, do you have thoughts on that? Like, how do we rethink, the way it's being taught or practiced in dominant institutions, like the prevailing institutions, is what I'm asking.
I think so. I mean, I think actually, when you look into the curriculum, where a doctor has to be trained as a psychiatrist, community psychiatry is an important
element.
component. But I don't think every institution follows that. Of course, when you have access, people do agree to do that. I mean, I have had experiences where some of my teachers have really understood what this means, and they have had all their postgraduates trained in basic certificate course in palliative medicine, in Trivandrum.
Yeah.
So many of them got trained, and they had the postgraduates had posting in Pallium India.
Sure.
So there are people who really welcome such aspects, but not as a norm. Not as a norm. Yeah, I mean, I think that the curriculum has to have this, and not as just as community psychiatry. See, in psychiatry also, when community psychiatry comes up, it is seen as a separate specialty or one aspect of psychiatry, not as something which has to be integrated with the whole system in terms of, like, when this person goes back home, who's going to take care of them? So let us have, so like, when you think of NHS in the UK, they are a good example where they do have a community team for all specialties, where there would be a community nurse or a social worker who's going to be looking after people, and their GP is actually in the community, who is their first point of contact. So I think, I mean, it's very difficult for us to replicate such models in India. But then, yes, and the WHO says, and there are the district mental health program also trains the primary healthcare physicians to take care of mental illness at the basic level in the community itself. But then that also has to come from the institutions. Institutions also should give back that, and that partnership should be there, so that this becomes a smooth kind of functioning, where people who are being trained are sent also to these communities to have this realistic picture in front of them.
Yeah.
I don't know how many of them know what's happening, with these families. So, and that's exactly why I say these home visits are very important, that you go and see, because especially in Kerala, people come, to hospitals quite well dressed, neat, even if they come from a very poor family.
Sure.
But you don't know how are they living, what is happening to their homes.
Yes. Yeah.
So now that I can see district mental health program have started home visits. So there is a change, but that has to be sustained and much more clear in terms of how we have this, just like people have rural postings. Doctors have rural postings now. So I think psychiatry also should have that part of it attached to this training. I mean, and important institutions like NIMHANS have community. Vellore has a very good community psychiatry wing, and the postgraduates there would have an exposure. But again, it should not be a standalone project kind of thing. That's what I'm trying to say. I'm trying to say that this person-centered care approach should be instilled into that training from undergraduate itself. So that is why the curriculum now has this attitude, behavior, and they have that kind of a module now in undergraduate training, and that should be there for postgraduates as well. So looking into knowledge, attitude, skills, the competence of what they have, not only in terms of diagnosing an illness and curing it, but also how do you approach, how do you establish a relationship, how do you engage with them in the community, engage with the families.
Thank you. And I just wanted to ask you that in all of this, I mean, you've been talking about yourself as a medical professional, but I was wondering if there's a specific inflection of being a woman practicing as a medical professional in these experiences.
Yes, being a woman, has its challenges. I mean, even in a state like Kerala, it's not very obvious. I mean, obviously we are. I mean, I'm part of this organization for 14 years, and I've been leading it. And most of my team members, not planned though, are women. And at one point, we were only women in Mehac, and they're not at all deliberate. But and in palliative care also, the women kind of the number of women in palliative care are more. Um, I had seen this discussed somewhere also in a almost in a disparaging manner. So I can't say that I have been subjected to obvious kind of gender bias or something, but it is there. Subtle forms of it is reflected everywhere, even in this very democratic palliative care settings, where decision in terms of decision making, in terms of the responsibilities given to you, how you are treating within a team. It's very subtle and it's not probably deliberate also, but it's part of that. How people behave in a when you're in a group and all those things. So very subtle. I mean, I also think like in other manners, in other ways also, like like when you plan a program, you don't plan for a woman. I think that is also important. It's not only the emotional or the behavioral part of it. I think we should learn from other countries how a project is planned, like making sure that the travel of a woman it can be safer. Safer means I'm not saying that it should be not in the terms of security, but in terms of is it comfortable for a woman traveling? Are there bathrooms in that the hall? That I think this is one important issue that every young woman would think of when she plans a travel. So are there bathrooms? Where does this person go and kind of change or kind of, so all these things are also part of a gender. I think those are also important because when men plan, they don't usually think about it. I'm not saying all men are like that, but then they don't think about it. It doesn't come to their mind, and women are expected to just adjust just like men do, which is not possible for women. So I think all those aspects also come under gender issues, isn't it? It's not only about how you're treated in terms of within the team, but also in terms of some facilities that because even like this brings up this issue of this period leaves also, and how it was not sanctioned in the central government, and it was normalized. And of course, it's for many women, it's a normal phenomenon for every woman, but it's not the same experience for every woman. So we need to be very considerate and compassionate for such aspects also. So I think that's a gender issue, but and also how women are encouraged or facilitated to be leaders. I think that's what when you say that when the democracy of it, I think leaders should definitely take a proactive role in facilitating women, especially other disciplines, to become leaders of their own. Because we have been in a very patriarchal kind of setting. So when you facilitate, it's easier to facilitate a doctor, but someone who's down the hierarchy, how do you facilitate them? Like Asha volunteers is such a very strong concept, and how the role of an Asha volunteer is in the community is so encouraging and so interesting to watch and witness. So similarly, we have to make a proactive attempt to facilitate people in this hierarchical setting consciously and deliberately and proactively. Leaders should do that so that this, and I'm not talking about the freedom that a woman has in terms of, we shouldn't give any hoot to other people's, men or something. I'm not that kind of, I'm not talking about that kind of a liberalistic kind of view. I'm saying that, of course, there are some aspects that men are more competent, some physical tasks, some leadership, conversations. Sometimes men deal it with well, but then have a discussion and involve women in your team. I'm saying like that, so that the inclusive aspects are also there.
Sure. No, I was thinking of that particularly because you talked so much about the travel.
Yeah. I have struggled a lot in the beginning, and that's exactly why I said the pandemic actually gave us opportunities to think about many things, about how we travel, how much should we travel, who should travel, and all those things. So I think we always have to go back and reflect and rethink about how we have been working. And gender is an important aspect of that. And it's also about people who we see. I mean, people could also say that this is kind of, people, when we talk about the past, it is always kind of rosy, isn't it?
Sure.
But
as you pointed out, I think there's certain structural changes have
also,
and
yeah. So also people coming into palliative care now want to do MD palliative medicine, and then they get a job in an institution where there is a department. So they will naturally choose to go there.
Yeah.
So those are the changes also in palliative care. Yeah.
And just the last question from my side, which is that, what do you see as the next steps for Mehac? What are you doing right now? What do you see going forward? If there's something that you'd like to share with us.
So maybe you had a role also in some of the things that I do. I thank you for that also. Because, when we work as a not-profit organization, there is also a tendency to kind of sometimes become a bit stagnant because you kind of keep doing the work that you do. So we have been kind of brainstorming as a team to see how we can grow as an organization also. So one thing is I encourage people to grow as individuals, which will help the organization. And also, rather than for me, my intention was never to make Mehac big, in the sense that like a big organization, take care of people all over. It was never that. It is just a model, a feasible model which people can learn from and replicate. Sure. So I would always want to keep this smaller, which is manageable, so that we can focus on the outcomes clearly, in the sense that maintain the quality, maintain the, and the numbers. We will never be able to take care of the whole of even the Ernakulam district. So there is no meaning for me to say that we want to make Mehac become a bigger organization in that sense. But how we want to grow is by doing research. We are doing research, and you had given me that seed of thought initially. We thought that for palliative care, and we had written a proposal, and now I'm doing that for mental health. We are actually doing a very good piece of research in terms of participatory research in the community, looking at one panchayat where we are looking at the community itself as how they influence the development of models. So it's not about us going and imposing models, but what do they think in terms of how the model is, and how do we modify the models according to their needs. So that, and we are doing that as an ICMR project. So research is something which interests me, so that I think that also helps us to understand the processes of what we do, and also we can modify and improve and bring in people also to work in. People would love to come and do research in the organization than work. So that's something we want to diversify into. Already started, but more also. And then I think we are diversifying into different programs. Like, rather than doing the same model, like Home Again is another program that we want to do. We already have 3 Home Agains with Mehac. So 2 are in Palakkad district. We started in the community. We have started a child and adolescent clinic, rather than just a mental health clinic. One panchayat asked us to start just for children. So we have started a child and adolescent clinic. In some panchayats, one panchayat has asked for a specific program for substance use, because alcohol use is more. So we are looking at adding components to the existing program according to the needs of that community, so that the growth will be in that way, rather than just doing the same program. We are trying to add on to the existing program and grow. So that is one initiative we are doing. We focus a lot on partnerships. So we do not believe in working alone. Because we don't. I think the growth of the whole of healthcare is only with partnerships, and I hope that the partnerships with governmental, non-governmental, and other private sectors improve and sustain, so that only then we can address the gap in whichever healthcare domain we are looking at, especially in mental health. We need to focus on stakeholder, other stakeholders coming in and partnerships. So we look for partnerships, and we establish partnerships, and we kind of work with them and see how we can do according to their needs. So that is one thing we are doing. Like, for example, during COVID, we were requested for helplines. So we never had a helpline in that sense.
Sure. Yes. Yeah.
So then during COVID, we had a very active helpline working. So then we were requested to have an urban clinic in Cochin during COVID because people wanted quick access. So the urban clinic still runs.
That's amazing.
So we have one. So similarly, so we are trying to, so now we have requests from corporate IT agencies for programs to look at wellness in workplace.
Sure.
So we are now we are developing modules to deliver that when we have a request. So in that way, we are kind of trying to diversify.
Yeah.
Individually, I think my role would be to encourage, like I said, leadership, and more come into more of mentorship and supervision, and look after research, and look at how we can make programs sustainable. Yeah.
Thank you so much for sharing all of this with us. We really wish Mehac all the very best, as well as to you, because we think this is fantastic work, and we think that there should be more such work across the country, across the world. So
I mean, I think this is a very replicable, feasible model. You just need a psychiatrist once a month and someone whom you can call. You need a social worker and the Asha volunteers. Every panchayat can start this because it's easy. Because when I started, sorry to go again, because when we began Mehac, it was very difficult to make medicines available in the community because medical officers found it hard to implement, because they have to make implement the medications, to buy the medications. So they are in charge of buying medications for the whole of primary. So to buy the psychotropics, the medications for mental illness, was a challenge for them. But now I see it coming in quite easily in Kerala. And also because palliative care also has some psychotropics in their essential list, so it becomes easy, and we work with palliative care in every panchayat, so it becomes easy for us. So I think that's also a change that we have seen, in terms of how the primary health center also responds to us, that they are ready to implement projects. The panchayat is ready to implement the project, and the PHC, the health service part of it, is also keen to get them so that people are treated in the community at that. I don't know how this came in. I mean,
because we were talking about replicability. We were talking about, I was saying
so every PHC can now get medications also. Yeah.
No, so thank you so much for sharing all of this with us.
I mean, and this purely comes from my own experience. So I know that some things can be debated on, some aspects that I spoke about are surely debated on. But it was not meant to say anything, it was not judgmental or critical, but my experience that this is what I am witnessing now. Yeah.
Also, this conversation was intended in that sense. This is not an academic conversation where, we, like you said, we have our respective research papers, our writings there, but this intent is to have a conversation what we are thinking about when we're thinking about care and healthcare, right? So thank you so much for sharing that.
I would also say, because I was invited for a TEDx talk just during COVID, like it was, I think, 2021. And I was asked to talk about palliative care and how it should change. The theme of that TEDx was changing the colloquy, So so that is again what I'm saying. I mean, it was supposed to come from my experience and how palliative care actually changes the colloquy. And I think it changes, for me, it changed even the way I would deliver mental health care, and also personally, how I see myself as a person delivering care. So that is the sum of it.
No, makes sense. And that's precisely the objective, which is that how do we just at least question the way we're thinking about the normal, just the way we're thinking about care, healthcare in the normal, and maybe if possible.
And I also think that, educational institutions should offer people, because you see medical graduates from outside India, like UK, they come for electives. So they take a year off
Yes.
when they are training, or they take some and they go to interesting settings and see what's happening there. And I think that's a good way of giving the stimulating people's mind.